Lizard.
So why are you so hard on our residents then when we're trying to teach them? They're in the same boat.
Hi, it's Abby here at Banter at the Bedside. And before you dive into this week's episode, us shift talkers felt like we would be doing a disservice if we didn't add a bit of a disclaimer here. See, this was one of our first podcast episodes that we recorded, and you'll be able to kind of tell that we're still getting comfortable with each other and really learning how to have those hard conversations and challenge one another. You'll also feel like there's a bit of the state of healthcare that's missing, that we're not talking about certain things. And that's kind of true. We are missing it because we don't touch on politics at all in this episode. And the current politics and the current political climate around healthcare and decisions around healthcare are going to have long-lasting effects on the state of healthcare. We didn't touch on politics because we were trying to avoid it or we didn't want to talk about it. It really just wasn't such a focal point at that time. And instead, we kind of talked about the state of healthcare and how it affects our day-to-day work. And you'll see more of that in the episode to come. Rest assured, we have full intentions of talking about the politics that are occurring around healthcare. And we're kind of excited to dive deeper into these conversations because the state of healthcare is an everlasting topic that we're going to continually revisit. So send us your comments, your stories, and what part of the state of healthcare you want us to touch on, because we want to talk about all of it and challenge each other and grow together through all of it. Thank you so much for being here for episode 3. We're so grateful, and we hope to see you in episode 4. That's all I have, so enjoy the episode, and I'll see you on the other side. Bye. Welcome to Banter at the Bedside, where scrubs meet real talk. We're here to pull back the curtains on healthcare, the stories, the struggles, and the laughs that all come with life inside and outside the hospital walls. Whether you're in our field or just curious what it's really like behind the badge, you're in the right place. You're here with all the shift talkers. Before we dive in, though, there's a quick note. We're healthcare professionals, but this is a podcast for a conversation entertainment only. No, nothing here is medical advice, and always talk to your own healthcare provider or do your own research for your health and medical needs. The opinions shared are our own and don't represent any employer or organization. I'm one of your hosts. I'm Abby, and I'm a nurse practitioner of 7 years in the cardiac ICU. I'm going to hand it off to one of my co-hosts, Caitlin, who's sitting right next to me.
Hi, I'm Caitlin. I'm a registered nurse, and I've been in healthcare for only 4 years.
Next up, we have Haas.
Hi, how you doing? I'm Haz Khaleesi. I'm a pulmonologist and intensive care specialist. I've been in healthcare now for about 13 years, so I'm the old guy on the show here.
And Kaylee.
Hey, I'm Kaylee. I'm a nurse. I've been a nurse for 17 years. I work in the cardiac ICU.
So Haas is not the oldest guy in the group, though, or in healthcare. I also have 17 years in healthcare. Way to try and claim that title.
It's just because I want to, describe the white hairs that are, in everybody's screen right now. So it was just the masala for the little bit of flavor that we have.
I've been doing this so long. Not as long as Kaylee and I.
Yeah, fair, fun.
One of the things I wanted to open us up about was really why we wanted to start this podcast and what makes us different compared to other ones. I wanted to bring everyone to the table. So we have a nurse practitioner, we have a physician, we have nurses, and in the future we're hoping to have pharmacists and respiratory therapists, nursing assistants, speech pathologists, whatever the topic may call for, to get everyone to the table so that we all have a voice, because we're all one team and we all need to start talking like a team.
Yeah, no, absolutely. And I think I think everything that Abby just said is just, it's really nice to get everybody's point of view. And I think what you're going to get over here is a lot of real talk, which is, I think, is going to be the nice piece to it compared to other podcasts that you may see.
I think it's really important that we do this in this day and age because our healthcare system is probably not the healthiest in terms of, yes, in care that we give, it's great, but in terms of teams and how we're functioning since COVID, I think I've seen a big decline. And I feel that sometimes social media and how we've become very segregated on it has contributed.
Piggyback on what Abby's saying. I think since COVID, if we were to choose one word to describe what I feel about where healthcare is right now, I'm not sure if the rest of the hosts feel the same way. I'm a bit nervous, really, where we are right now. We've had a steady decline of outcomes. We've had a steady decline of people seeking medical care. People have lost trust into the system, which is really, really concerning for the most of us that are here, because we kind of given our lives up to this. And I feel like nowadays we have to convince as much as we have to treat. So it's really important that you get to see this side.
Yeah, it really has changed. I think we say a lot. It's not even always the patients, it's the family, and it's that mistrust. And I wonder how much social media contributes when they see us talking about each other on social media. Like your FYP page does not just stay within the healthcare community. Like these TikToks and Reddit threads and YouTube videos, they all go out to everyone and everyone can see it. So when you're bashing a provider, whether it's a nurse to a doctor to a nurse practitioner, there's people that see that, and then it really makes people question your ability. And I experience that a lot as a nurse practitioner. There's a lot of times I'll go in and they'll be like, I want the doctor, I don't want you. And it's like, okay, you can talk to him, but he's going to say the same thing. Mainly because I usually have to be like, this is this patient. This is what we're doing. Just remember, I know you have a lot of patients, but this is this one.
I think medical shows play a big part in it too, because they've been more popular and they set really high expectations that just, there's no way any of that could happen in real life. And then it also portrays us as nurses and doctors in a certain way where that can kind of change how people feel about it. It's a lot of really high expectations, which we try to meet that, but some of them can be a bit unrealistic.
Yeah, I agree.
You know, people got into this to take care of people and form relationships. And I think a big piece of it, I know, I'm just going to raise my hand and be like, the epic gods and the EMRs have kind of taken that big piece away from us, especially me in clinic on top of all of that. In the ICUs, it's a little bit different, but we can't relate anymore. And that's a really big piece. And some of the best times that I've had with patients is when I see them in follow-ups that I've been seeing them for a few years now, and we can just shoot the because I think it's really important to form those relationships. And it goes back to what Abby was saying earlier, because if you form that relationship with people, you can gain the trust of that family, mainly because we're kind of in this together. I'm not trying to do something to you that I wouldn't do to one of my own family members, but how do I convince you of that if you don't see me as a human being yourself? And I think what the shows are doing nowadays, they're obviously entertainment purposes, which is what we're trying to do over here. But can I talk about one show, for example? How do y'all feel about The Pit?
I haven't seen it.
I like The Pit.
I watched it yet.
Okay, so it will blow your mind that entire season was one day. Okay.
It's like 24, the TV show 24.
Mhm.
I have heard that, and I thought that's like a really interesting concept for a hospital show because we are a 24/7 service.
Yeah, and like we'll have those days. Everybody here's had those days where you'll have 9 admissions. You won't even know when that patient rolled in. Like, whose granny is this? Whose Mima is that? That just popped in when you've just been lining and tubing and putting a patient on pump or whatever else that's like happening. So part of it was real, but at the same time, What I didn't like about it is that you cannot burden people with that much happening in a 12-hour shift and expect that it's going to be good care for people. It also sets an unreal expectation out of people.
Mm-hmm.
Like, I think
Mm-hmm.
people forget sometimes that, hey, you know what? I may miss something. It's not intentional. It's not because I didn't care about you or your loved one or wasn't that case, but sometimes things are not as quick as you may want them to be. And I don't like the unrealism that may happen from these things sometimes because it looks bad on us. Because at the end, we're the ones that always get the phone pointed as like, this happened to my dad because of you.
Yeah. Oh, yeah. And it's the quickness too on the shows is always going to be unrealistic because they have to drive the show forward in a way. They can't wait the true 48 hours that it takes for us to get a stat MRI. And that's just the truth. It takes 48 hours sometimes to get a stat MRI because there's so many. And when you're at a facility that has 2 MRI machines, like it takes days, and shows don't convey that. Again, because they don't have the time to convey that in a real show. But
If I had a shift like the 12 hours on the pit, I would have left maybe 3 hours in and just quit altogether.
why? What happens?
Everything. I mean, everything that you can think of. A kid dies. They have to do the
It's a mass
Minnesota.
casualty event.
Yeah.
Yeah.
And
Is
then
it
they
set in
think
the
there's an active
emergency
shooter
department?
at the
The
hospital.
ER. And I'm like, what? Nothing against our ER friends, but I'm like, what ED runs all of that stuff? They're having palliative care talks down there. I'm like,
Oh.
I would die for that if I had an ED run a palliative care talk before starting the 2 mics of level fed. So we have to go have that talk. You know?
Right.
No,
Yeah.
that was the worst. That had to have been the worst shift ever. There's no way. No.
That whole team quits.
Oh, 100%. They're not coming back tomorrow.
Not good.
No call, no show.
Don't worry. They'll call a code lavender for them.
No, yeah,
Yeah.
no. I would have needed a code lavender maybe 2 hours into that shift. It was
What
What
awful.
about the med student that were floating aortic catheters down?
Oh, yeah.
Yeah, and I was like, the
Yeah,
med
yeah.
students doing that.
What?
That's incredible.
Yeah.
Good,
Yeah.
good TV though. Good TV.
Good TV. But yeah, unrealistic expectations for people that watch it. I think the one that always gets me is asystole shows
Oh yeah.
and shocking it. And then when we have to discuss that with families, I'm like, yeah, like there's only 2 that we can actually shock. And they're like, what? And it's
Mhm.
like, yeah, that's
How about just about asystole? Let's just bring it back a bit to real life. Why does EMS do CPR when they find a patient in asystole?
oh, there's actually rules about that.
Mhm.
They
So
have
I
to
know,
have,
I remember you told me once,
yeah,
but
they have to have rigor mortis set in or in the active, like, and it varies state by state. But in our state, you have to have, as we call it, the golden ticket, the DNR form with you. The DNR bracelet doesn't count. I know the DNR tattoos are popular, but that also doesn't count. Or the family has to say, don't do it, but rigor mortis has to set in, and that's 2 hours. Takes 2 hours for it to set in.
I mean,
Minimum,
could be
because,
like, yeah.
well, because we
Yeah.
keep the patient. I mean, Kaylee and Caitlin, they can stay in the unit 2 hours and I haven't done postmortem care in years now. But, I mean, you can do postmortem care for a while and they're not stiff and rigor
Yeah.
yet.
It depends on how sick they were before they passed, we could say. But yeah, EMS has to, I believe, just like you said, unless they're like clearly have been that way for a while, like legally they have to start.
Yeah. And in our state, it's legally until rigor mortis is set in. So they have to be like unmovable. And then that's still a judgment call, like, I think for some of them.
Hmm.
So Abby, I know you had a really good question that kind of a nice secondary icebreaker for us is that what do you see as the biggest challenge in healthcare from your perspective right now?
I think our biggest challenge, in my viewpoint, is I think it's staffing, but I think it's staffing all around. having started healthcare when I was like about 17, having worked with like paper charting and worked in a nursing home, worked in a rehab, hospice, step down, seeing kind of that progression. And then moving from a bedside nurse to a nurse practitioner, I'm starting to feel like a sandwich, almost like the sandwich generation, but like a sandwich provider. And I have like new doctors becoming new attendings, and they don't know what to do. They can't order even potassium without my help. And then I have new nurses coming, and I've messaged Caitlin and Kaylee multiple times, like, oh, I was nurse. I mean, they're like, oh, Abby's in Nurse Abby mode. I'm putting in Foley's regularly. I'm putting in NG tubes regularly, like, because the skills aren't there. And I think that there's so much to learn now. And so staff just aren't all around. Even nurse practitioners, students aren't coming out ready for what we really all need to do. So I think those of us that have been around a long time and have all of these skills, how do we pass it on? How do we prep them? How do we get everyone ready for this next wave? To me, that's my biggest concern is how do we prep the younger generations? Because we can't bully anymore. And I'll say that's how I was taught. I was bullied by my charge nurse at the nursing home, by my nurses on my step down unit. I didn't love it. I'm not saying we should go back to it, but I did learn. So how do we teach and get everyone ready? That's my biggest concern. What
Yeah.
about you guys as
I think
nurses?
staffing for sure. I mean, so I've been a nurse for a long time. I've worked on an intermediate floor in the ICU, and of course, we've gotten pulled to almost every unit in the hospital. So we've gotten exposure to lots of different places. But like the amount of nurses that we used to staff on a shift for like a certain census compared to now is crazy. I mean, we always have a free charge for the most part, but we would always have the float nurse. We would have multiple CNAs on the floor. We would have our own dedicated EVS workers. So everything just flowed and you had enough resources. Now, not only is it less nurses, it's less experienced nurses, like you said. We have less techs. We don't have our own dedicated staff. So you're doing more with less, but you're also doing more with less experience, and the patients are sicker. So I find it I find that to be the biggest struggle. I just feel like it borders on getting into that unsafe region a lot, and we're trying our best, but as you know, as one person, you can only do so much, and when you're the main resource for everybody, um, it's a big struggle, and I don't really know how it can be fixed with the way they do the staffing based on like a budget instead of safety.
What about you? I mean, 4 years in, what?
I think when I started in cardiac surgery, we had so much experience on the floor that you knew when you came in, you were good. Even as a new grad, you knew that, well, I've got this person, this person, this person. Tonight will be okay. If everything were to go wrong, it would be okay. And then those experienced, really good nurses leave bedside, whether they're tired of bedside, whether they're tired of core staff pay at bedside and they want to go travel, or they get in a nurse practitioner school or CRNA school. You lose good, experienced nurses, and there's no way to make up for that experience with a couple of new grads. There's no way that you're going to retain all of that information that that patient or that staff member had with just a couple of new grads because they're just not there yet. So then there's this big gap of people that have been there a little bit and then people that have been there a couple of years, but there's a huge gap of people that have been there a long time that you would feel comfortable with if anything were to go wrong. I mean, you look at the schedule and you're like, "Gee."
I'll be honest, I pick my patients every morning based off what nurse is in the available patient.
Well,
I
and
go
not
and
only
look.
that, that gap, the experienced nurses are not the ones training the new people.
No.
The new grads or the ones who've been there for less than 2 years are training the new grads. So it's almost like this snowball effect.
Mhm.
I will say, coming from just having graduated with my leadership doctorate, there is some method to that madness. It's just like, I don't think it's executed the right way.
Right.
So there is good research in showing, like, if you increase engagement of low engagement people, or when you give them kind of a role, they'll become more engaged and take their job more seriously. It does help. I don't know if it's executed right. So there is some method to the madness of, like, okay, we're going to take a younger nurse and pair them in orientation, because hopefully it will drive them to be better. Because when they're asked a question and they don't know the answer, they're going to go look it up and they're going to go learn it. It's just not happening, or we're not selecting the right people.
Right.
But I think there are some people on our unit that when they get a learner, you're like, oh, okay. Or when they're put into charge, you're like, oh, okay, you're taking your job more seriously. And I can say, as a NP, going through school and seeing, like, the provider side, that also, like, happened to me, and I see it happen with a lot of NP students that I have, is they suddenly, you kind of have this switch flipped of, like, oh, I'm a way better nurse. I'm way kinder to my providers on shift, because now I understand what it's like on the other side. So there is some method. I don't think we're executing it right, though. I think they're just like, someone saw it, heard it at a conference, and now we're just blanket all the new people, orient the new grads, and maybe one or two will grow from the experience.
And
you
just
have
the sheer
some
number
nurses.
of new grads.
Yeah.
Yeah, the sheer number.
Yeah. Well, like, literally every full-time person that works on our unit has a new grad with them.
I'm like,
So
where are we getting them? What nursing school is producing all of these new grads? There's other hospitals.
Yeah. Well, then you have some of them that get paired with, the 1 year, 2 year experienced nurse. And some of them will ask questions, and then some of them will come up. Like, the past couple of shifts, that TikTok sound where it's like lizard, lizard, lizard. And I'm just sitting there, typing away with my little new grad, and they go, Caitlin, can you come look at this? Caitlin, do you mind coming to do this? Caitlin, and you're like, I need double clinical coach pay, okay? Double. Because I'm helping this one too. And then but those are the ones you're thankful for, because at least they're coming up and asking.
Yeah.
Before they do something completely heinous that wouldn't be good. But yeah.
Yeah, that's true.
But
like giving 150 to a non-intubated patient.
we just scan.
Yeah.
It's just
That
checking the
should
box.
trigger you that something is wrong if you're scanning it, though, right?
Right.
To be fair, it was ordered. It was forgotten to be discontinued. The end result, it was safe. So end result, I wasn't overly angry. But yeah, like, if they would have maybe asked a question, like, hey,
Why are we
what
giving
is
this?
this?
Yeah.
Should I be giving it?
Mhm.
Any of those?
Mhm.
So I would
But
say for me, it's probably burden. And I think burden is a big worrisome thing. I just recently started the show called Severance on the flight back yesterday. And that's kind of how I feel like how my life is. Like, I feel like I come to the hospital, and as soon as I walk through those doors, and I feel like I completely dissociate from the rest of society, and I'm just involved about what's happening. My family's taking a hit for it. My wife is taking a hit for it. My friends are, because for those 8, 10, 12, 14, 16 hours, whatever that it is I'm completely severed from the rest of society. And it's kind of hard to deal with that, because you have two personalities. You do have two versions of yourself. I'm not sure if you do. I don't want to speak for y'all, but I have two versions of myself. I have a version that's at the hospital, and I have a version that's at the clinic and in the bronch lab, and then I have a version that's at home with my wife and with my family. And it's really hard. Then I have a version when I'm in a teaching role, just like you guys are at. And I wanted to ask y'all a question about that. I love everything that you're saying right now, how you're bringing up the baby nurses. So why are you so hard on our residents then when we're trying to teach them? They're in the same boat. They're still trying to learn.
Mm,
I think
Mhm.
well, I'll let Kaylee start. I see a
No,
different side.
what I was gonna say is try to give them grace when they start, because it's in the ICU, and I feel like that is really tough. But I think sometimes I know I can do this. I don't want to be like this, but with everything that's going on, like my patience just gets a little bit low, and it's like if I'm going to you because I need help and you can't help me, and there's nobody else to help me, and you're not being supervised, and you're not even in my like chain of command. Like I'm a nurse and you're the doctor. I think sometimes it's just a frustration of I need help, but I can't tell you how to help me and also do all of my stuff and help everybody else I'm supposed to be doing. But I do try to give them a chance. I know I could work on that. I feel like we all could, but it's just like as I keep going, I have the same level of experience, and then it's just like another baby coming in, and I just need them to maybe be prepped a little bit better or have a better buddy with the fellow, or I don't know a good system of that because I'm not a doctor, I'm a nurse, but
The only reason why I brought it up is that I love how you all nurture these young nurses that are coming up. And I can see the ones that are paired because we're watching too, just so you guys know. And it may seem like we're completely airheaded and lost at the entire time, but actually, I think all of us, half of our job is awareness, right? You know when somebody's lying, right? Because we interview people for a living, right? Everything that we do is in interviewing another human being. Everything is regard to questions and the history taking, because that's where the story is. The proof is in the pudding there. So the way I see it is that when your baby nurses, how you guys like to call them sometimes, right, make a mistake, it's quickly covered up and taken care of, as you should defend them.
covered
Okay.
up.
I don't know
Sorry,
if
let me
it's
bring the
covered
word back.
up.
Let me bring the word
covered
back.
up.
Let me
Yeah.
bring the word back. I said you're protecting them because they're
Yeah,
learning,
yeah.
right? So think about that now. Let's switch roles because I want you to get into my world a little bit. I have medical students that are supposed to be, and this goes back to what you were saying, Abby. We have to worry about the next generation. And I'm
Mhm.
going to be an old guy and say this snowflake generation isn't ready to learn, because I also agree that I think tough love works in medicine, because if you don't have that fear of making a mistake, if you're not scared I'm still scared every single day. Every time that I come in, I still say my prayers. I still like, hey, I hope I don't hurt anybody today, because what we do is literally life and death. So as these baby medical students who have given up their entire life are coming in and finally learning how to touch a patient, hey, these are lungs, this is a heart, this is a machine, this is that. They also have to evolve, because at one point they're going to be making big decisions. So there's some nurses that are helping them in the evolution. And we tell them, I'm not sure if you guys know, we tell them, hey, well, listen to your ICU nurses. Listen to your ICU acute care nurse practitioners. They've been doing this longer than you have. You will learn from them, because we can learn from everybody. I just personally feel that the nursing profession isn't as kind to younger doctors, and I just want to make it better for everybody.
Yeah.
It's a
Well,
controversial piece, but this is what we're here to
the-
talk about, right?
Yeah. No.
The part
I would
that
agree. I would
will-
agree with what you said.
Yeah, but
Oh,
the
yeah.
part we have to piggyback off of is the hospital system as a whole will throw the nurse under the bus before they do any doctor or fellow. And so if I need a restraint order, and I've told you now 4 times that I need the restraint order put in, and then I go, I need a couple of things. You want me to write it down? No, I'll remember. And then 6 hours later, you finally throw it in. That's not legal. That doesn't meet any of the requirements that the hospital has to have. And it's just, I can't do it without an order. And that's the biggest problem I have. And that's why I work night shift, because I can't.
But what if we move fellows onto nights?
I'll go work at a clinic.
Well, then they gonna have to learn today.
No, I'm
They
just
gonna have to
kidding.
really start learning. They
Yeah.
really are.
I mean,
But
it's just
everything that you guys just talked about kind of highlights something important, is that we can't take care of patients.
Yeah.
Because
Yeah.
I'm worried about the order. I'm worried about this thing
Right.
wasn't done in right. This thing wasn't signed the other day. Okay.
Right.
And then I've had to put in a verbal
Oh.
order, and then it won't get signed when
Right.
it
Yeah.
goes over. And then my manager's like, "Well, they wouldn't sign
Love
it." I'm
verbal
like,
orders. But let's talk a little bit about more about this. Let me just tell you, so you know how hard it is for these lung cancer patients that I need a tissue biopsy, and then you finally get that approved to come down, and then my fellow signed the consent with this. This is some policy Okay. The patient came down finally. We're literally prepping the patient. They're getting their IV to go get the E-bus to get done. And on the consent, the date wasn't on, but the patient signed, the witness signed, everybody else signed. Okay. And now the patient's delirious because they've been in the hospital for 3 days waiting for this bronch. They can't do a reconsent. So I had to call a legal who I have on speed dial for many of reasons, including my citizens arrests that I've done in the past at the hospital.
Multiple
Multiple of them, okay.
citizens arrests
And I'm from Canada.
as a Canadian.
As a Canadian. Fake citizen. So
non-voting citizen doing citizens arrests.
see this crap. We'll tell you that story at a different time. That's a good story. So the case had to get delayed because now the patient's spouse we couldn't find the patient, and we reached the 2:45 mark. I mean, I got the tissue diagnosis, but an hour and a half delay because of some policy because I can't take care of a patient. That saved me another hour where I could have seen somebody else, but I couldn't because here I am doing this crap.
Oh, I'll top you one better. It's the stupid little check boxes at the top of our consents.
Oh, God.
That's why we're in blood jail again.
Yeah, and blood consent is the one that I don't know what it is. Okay, all nurses hate giving blood, and it's not even like the worst thing to do. It's just annoying. But transitioning from a bedside nurse hating giving blood, even though all I have to do is get the consent, I hate getting blood consent more than so many things. I would rather swan a right-sided heart failure patient, which is so difficult, that's awake, non-intubated, than get blood consent. That's how much I hate getting blood consent. And then they come to me at 2 a.m. and it's like, we have to redo it because the stupid little tiny box wasn't checked.
Mm-hmm.
Yep.
And then it's like you have to explain. The worst part is then I have to go in and explain to the family, yes, we have to redo this because this little box wasn't checked.
You know what's crazy?
And then if they get transferred to another hospital, a whole new one.
A whole
Even
new
though it's
one.
the same health system. It's silly.
And it's just like you're touching on, it's a delay in care. Like, it's delaying things, and the hospital wants to talk about throughput. Like for you, waiting that extra hour and a half to get this done because of this silly consent is delaying our throughput. It's delaying care. It might not make matters worse in terms of like minutes, but it still delays you from seeing the next patient. It delays someone else from being able to move in and do the next bronch. Like, it's all a delay.
I'm actually happy you brought that up. So what is this thing again when you can put in this safety event? I'm forgetting the acronym. I've had too much fun in Spain. What is the acronym again?
Ours is
NSI?
PS.
Yes, okay. What is the deal with this? Okay, so listen. In the consent, so consent is two things, okay? So I'll tell you two stories, which is crazy. Consent here for everything. Just going back on blood, giving blood for hemoglobin of 6.8, want to kill myself, okay? Because of us being vampires and drawing blood. How about this? In Canada, if you show up at the hospital, okay, I'm going to bring things back to Canada a lot, okay, good? You have assumed consent because you came to the hospital for treatment, for things to be done for you, okay? Same with our dialysis patients, okay? So these patients have consented to dialysis 3 times a week outpatient. Then they come in their heart failure exacerbation, and we need to consent them for CRRT. Does that make sense? And there's other thing about these safety events now. So a part of the consent for, let's just say, a central line is a pneumothorax.
Mm-hmm.
If the patient gets a pneumothorax, why is that a safety event when it's a part of the consent? Let me tell you why. This is what it does. We had a great that has left our system now. I loved the guy, okay? And, being a director of a unit, so he came up to me before he left, and he was doing a TE on a guy, and the bedside nurse was uncomfortable with the sedation that he gave for this procedure, even though it was the intensivist that was doing it, wrote him up for that. And when he called me afterwards, he's like, this just makes proceduralists not want to do procedures.
Mm-hmm.
The nurse wrote the doctor up for the sedation that they gave?
Because, she felt like it was inhumane for what they gave. We should have been given more because he was uncomfortable. But this patient had an EF of 10. Okay. So giving a negative inotrope like propofol was not doing a good job. So it was a little bit of ketamine, a little bit of fentanyl, a little bit of Versed. Case went done, diagnosis made. Yes, aortic root abscess, blah, 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 slam dunk, this and that, everything happy. But the doctor got a report saying that, hey, there's a safety event on you because this person didn't like it. Or I've gotten one of these before where I was teaching a fellow to get a subclavian line. They were in a neck brace. No way around them with a C1 fracture, needed access, can't go to the FEMS, fungal infections, went through a subclavian, tried to do sides. One side got a pneumothorax. That went to peer review. Known complication from the procedure.
Yeah.
This is
It is.
Well,
yeah.
I think, and I don't know, but as this country is so happy.
Well, yeah.
I mean, over anything. I don't know how many
Ambulance
times
chasers.
we've been threatened that, I'm going to sue this place. And I remember one in particular, and something happened to them when they landed on top of the hospital. And every time you went in the room, you were reminded, I'm going to sue the company that we use part of the hospital. I mean, every single time. And you're, yeah, I mean, yeah, nothing's broken. You're no worse for the wear. You just have a bruise. But dead set on just sue. They called everybody in their phone talking about what had happened. Just excited to be able to sue.
Mm-hmm.
But
And
yeah.
I think, yeah, the Sue Happy, CYA, cover your medicine,
Defensive medicine.
defensive medicine is contributing. And I think that's even what you're seeing, like what we were talking about with like the residents and the nurses, and why can't we be nicer to the nurses? And it's like, because the hospital is so CYA as well. And so, yeah, they get on the nurses about that restraint order. They get on the nurses about your RAS score doesn't match what the order titration is. And all of that comes back to CYA, though. Like, if you're over sedating, one, you're practicing outside of your scope. If they're at a RAS -4, which is like super sedated for those that don't know. And then, but your order says keep them at a RAS -2, which is like medium sedation. But we verbally have said, no, we want them like really down so that they don't mess with the vent. But we haven't changed that order. Well, yeah, a lawyer can come in and be like, oh, look, they probably got this pressure ulcer because they were over sedated and the orders didn't match. Like, so it's all comes back to that. So then it's like their management gets on them. They get on the residents, and then it kind of creates this spiral of everyone's almost like protecting themselves.
Like the Spider-Man meme where
everyone's pointing.
Yeah. You're pointing. And that's part of, even the sedation stuff is part of our chart auditing. I mean, we get chart audited every 3 months. And that's one of the things. I mean, it's a 2-page document of just.
Oh, it's crazy.
We get the same thing.
It's awful. And it's just, that's one of the things. And then if you give a PRN med, you have to make sure that you document within the time frame. It's just stuff like that. And I don't know.
It is, as you said, it's the burden of medicine. It's making it harder. So many of us got into this to like connect and help people. And instead, I'm not always worried about harming someone, but, oh, am I going to get sued? Like, oh, am I going to lose my job? And that's not what I should be worrying about. We should be worrying about, like, I don't want to cause harm to anyone. And that's something that I think patients all need to know. I mean, you hear of like the serial killers in healthcare, but the vast majority of us are not here to cause harm. None of us want to cause harm. None of us are malicious in any way, shape, or form. We all want to help heal patients, whether that's because we love science or because we're healers and we like to take care of people. But like, that's something people need to understand.
Want my patient to get a pressure ulcer or drop a lung or get an infection because I just don't want that to happen to them. Like you said, I want to do a good job. I want the patient to get better. I want them to go out. But that's not why the hospital cares. The hospital cares because of what that costs or because the insurance companies won't reimburse us.
Mm-hmm.
Right.
So
And it comes
I think
directly out of the
that,
unit budget too. So then we're
right.
constantly drilled down about making sure we cover all of our bundles because if somebody gets a pressure injury, it's the hospital doesn't pay for it. The unit specifically pays for it. The unit pays for the CLAPSI. The unit pays for the CAUTI.
Oh, God. CLAPSIs and code.
Yeah.
Yeah.
Yeah. So when your patient gets here and they've just coded upstairs and you're putting in lines and you're going to an emergency T and you're giving blood, you saved them, but you didn't chart that skin swarm in 4 hours. And now
Okay.
you got dinged for that pressure ulcer that was already there. So, great job, but really you could have done a lot better because now we have to eat that. And it's like, it's so frustrating. I mean, we still want to come and do a good job, but it almost just makes you just be like, I can't do anything right. So,
Yeah, it's like if you're doing, if you
Mhm.
don't. Like if you spend this time sitting and charting and the patient and the family don't feel taken care of, then they complain on that end. And if you are in the room doing all the things and you miss some things charting, management comes after you.
And then
exactly.
if you stay late to chart, that's a whole nother problem too, because now you've gone over your allotted hours. And then you have to make a note, clocked out late due to patient care.
Yeah.
It's all back to a
Yeah.
note. It all comes back to that note.
I think there is a lot, but I think if people on the front lines can start to work together
Mm-hmm.
more, it will help. If we're all a team as opposed to individuals.
You're right. I mean, we need to be more comfortable talking to each other. It needs to be approachable. And I think a lot of times you're just nervous because of the stigma of, "Oh, I have to go up and talk to an attending." And we have really good attendings on nights. So it's just, it's hard to, I don't know, it can be difficult. And I think if we're communicate better, which is obviously the end goal for all of this, then it would be a lot better if we understood each other's side and how it has to go. But it's a lot. We're asking people to do a lot in the short amount of time that they're there. So we're asking to do more with less that we have to offer. And it makes it hard. But I think if we're realistic about what we need and what we want and we can communicate openly about that, then hopefully it'll help.
Yeah.
I'm hopeful.
Residents here because I feel like this is a venue where I can right now because this is a safe place with all you wonderful people. I also live with a resident right now, so it was a long time ago for me, but just to go back to that stress, and I gotta tell you, these people are stressed. The good ones. We have those ones that are careless, which I don't think they have a role in medicine, to be honest with you, and they'll probably learn that the hard way. But I just want, if I can make something clear to everybody here, that these people's lives suck. It's 80 hours a week, no trust, nobody wants to deal with them, and all they're trying to do is learn and get better. But then you get this one good resident from time to time, which there's a lot of them from where we work, and it kind of makes you feel hopeful about the future of medicine because remember, these people are going to be taking care of us, right? See Caitlin's face right now.
I'm so excited.
Yeah.
That's why I'm a DNR already.
Yeah.
I'm not
ready to
old
go.
enough.
No
I
thanks.
don't want to end up on our unit
No.
and have a coworker put a Foley in me.
I will say when I started NP school and I saw the flip side, I had a big change in my approach. Like when you don't understand how much you are hammer paged or now secure chat, which has made it even worse until
Way
you're
worse. Way
in
worse.
it. Like until you are holding a pager like that, like you can make assumptions or you can sit by your doctor friend and be like, oh yeah, like that's going off a lot. But, like, when you have to respond to every little thing, I got way more compassionate. Like, my last 2 years as a bedside nurse when I was in school, like, my residents, my fellows would be like, "Oh, thank God you're here today, Abby." And it was a flip. And I think that sometimes we need to see the other side to understand. And then because I had those relationships, then I would explain, okay, well, this is why my nurse is on you about this. Like, because if they aren't, then the family won't leave them alone. The family keeps coming out, or the nurse manager is going to get on them.
Too, like, so, we have a program on our, or we have like our intensivists and everything. But before that, we didn't have, APPs. We had residents who became fellows who became attendings like cardiology. Okay. And so we were kind of all in these trenches together. So it's like, I'm going to work with this resident because then he's going to be my fellow and then he's going to be my attending. And that's all I've got. Right. So there was a little more incentive, I guess, to maybe like really help each other because we were just struggling together. Whereas now it's like the residents come in, it's like this revolving door. They're gone in a few months and then they might come back as a fellow or they might not. Whereas with like our APPs and our intensivists, like we're kind of all in it together because we're always there. So I think it can be frustrating for me. I guess I can only speak from my perspective. It's like the residents come in, they're babies. They don't know what they're doing. That's okay. We help them. They might get to the point where they're like manageable on their own and then they're gone. The same thing with like the new grads. We train them for half a year. They only work there for 2 years and then they're gone. It's like so much time and effort put in to not really get like the output from that once they're able to work on their own and contribute. So it can be frustrating. I'm just saying.
I
They're going to
guess,
go off somewhere and take care of somebody, but
yeah,
it's like we don't get to reap the benefits from all of this continuous effort.
But that's education, though.
that's
I
education.
know.
That's education, right? No,
But
I get what you're saying. I get what you're saying. Like the people that you put in time into, you want them to stay because you've put in the time and the effort and you've trained them. There's a lot of fellows that I would love to stay that they don't, or that I put in 3-4 years into them. And I'm like, perfectly mold or tried to help mold this person be who they're going to be moving forward. They take the good from me. Hopefully they leave the bad from me. They take the good from others, just like your nurses. They take the good from whatever you're going to teach them. They're going to hopefully leave the bad. And we're not going to keep every single one of them. But I guess my whole point of it is that I've been selfish and I'm like, hey, this patient's really sick. I want Kaylee to take this patient when the patient's coming up, when you're not up for an admission, but just because I know of how good you are, how capable you are compared to which nurse was going to take it. And I probably feel like you guys have the same thing of where this patient should land, with doctor, which attending, or which fellow that gets it. But I guess the one part is that like you're going to see these evolutions, especially the ones that are going to stay. So why not make the relationships good early? Because we are going to be together at some point.
I think this is my question, because the nurses, when they have the baby nurse and there's someone that we're like yours right now, that we really like and we think is going to be a really strong nurse that we foster and we protect,
Mm-hmm.
why aren't the attendings doing that? Like, why? Like, which nurse or which APP or which person is going to maybe be a little rougher with them or have high expectations. So I don't feel like I see attendings taking the same protectiveness that the nurses do. Like,
I hope I am. I can't speak for the rest. I hope I do. I hope to always make everybody that I work with feel how much I appreciate them, because I cannot do any of it alone. And that's that's a funny part of it. It's who's actually practicing the medicine. Is it me? Is it you? I put in an order. You actually take care of it. Running that Polaris pump, 3 pumps, 3 drips. You guys are like painters when you have all those drips that are running at a specific time. It is art how all that shit is running. And that stupid CRT machine, I always step on that line and then I hear that fucking horn. I have no idea what the fuck they do there, other than the ventilator and saying shit out loud and doing things to patients. I'm not really involved. Right, so I'm hoping I'm there for this to maybe guide something, but I think that's just such a crazy thought. I think about it all the time, is that who's actually practicing? We all are. The way I see it is we all are. And the only way that that patient's going to do better is if we're all on that page. So I guess this will lead into a recent story that I had that was great teamwork. Okay. Why I still like this. I think we all kind of being in the ICU and jaded and cold-hearted at some point. You get these cases once in a while. This wasn't an ICU case. It was on the pulmonary consult service, but I had a young guy, smoker, really, really long time. Great family. You can tell this blue-collar dude's been working hard forever. Been short of breath 6 months. Came in, cannonball lesions everywhere. Lesions everywhere. Everybody here knows what this outcome is going to be. I looked at him and I said, "What do you want to do?" He said, "I want to live." That was all I needed to hear. They didn't need to do anything else. We got him tissue diagnosis from Plura, from the Bronx, radiation oncology nurses, ICU nurses. Another scenario, Abby, just to piggyback, couldn't get him down to the Bronx lab to do a biopsy on this guy. Okay. We tubed him in the MICU, bronched him in the MICU to get him a tissue diagnosis because we all know earlier treatment is better. I just got a message from him right now that he's at rehab and he's already gone through 5 fractions of radiation and going through chemo, and maybe he's going to see his kids for another 2 years. That one case will probably carry me another 6 months. So I'm really happy that I'm still get to be involved in things like this, because I think we all can agree with this, that we see people in their worst day of their life, right? They're going to remember us for the rest of their lives. How many of them do you remember? The patients that you've seen now.
I remember all of them.
Yeah,
Do you remember any?
I do remember.
Any stick out?
Oh, yeah.
Yeah.
Yeah. I mean, we had one when you were the attending that night, and it was a patient that had swallowed a clove, and anesthesia did not have the OR space to take him back there. And so this patient, who really should have just stayed in the ED, had to come up to our unit, and we had to admit and then just discharge him 30 minutes later because we just needed to do the endoscopy to be able to find this clove, which was already well into his small intestine.
That's right. I remember that.
Ew.
Really, remember that thyrotoxicosis we had? The one with the heart rate of 10,000 that we shocked 100 times, that we cannulated for VA ECMO that night? Remember?
Yeah.
Yeah.
Do I remember that? Yes, I remember that.
Yeah.
That was a rough night.
That was a rough night. Rough night.
I do think that there's like cases that I'll think back to, like you're saying, that like give me hope or remind me why I'm in this, or like why I do it. It reminds me that what we do matters, what we do changes things, and that if we can instill that hope, if we can remind young generations that we do make changes that make big differences in people's lives, maybe we can continue to improve our healthcare system.
And even, if the patients don't make it despite best efforts, like the families see that we did everything and they can like rest knowing that their loved one had everything done for them, and that, that's just how it was going to be. But a lot of times they're very grateful and they're just like, thank you for all your hard work. We saw everything y'all did. And, at least they had like as peaceful a death as they could have. So
Peaceful
sometimes,
death is a blessing. It's a blessing.
that can be a blessing. And I think that kind of stuff, we'll get the little cards written after the patients have gone, whether or not they got discharged or maybe they did pass away, and they'll send like clips with their obituary or like handwritten notes. And it's like, we just remember y'all. Thank you so much for everything. So I think that's like what sticks with me, because we just don't get a lot of thanks a lot of times for what we do. So I always appreciate it.
I agree. No, I totally agree. It's harder to have stuff that sticks with you on our unit specifically because the outcome usually isn't super great. Every once in a while you do have a really good outcome. When you do get, it's sad in some ways, but when you do get a thank you from a family member, it's nice. Just the other day, oh my gosh, thank you so much for taking care of my son. You're incredible. This has been great. And you're like, wow, what? It's just nice. It validates your feelings. It validates that you're a good nurse and you're doing what you need to do to take care of them. And you rarely get it unless it's like your friends or something like that. But I mean, just like a little thank you, like I'll remember that forever of just her being so appreciative because we just don't hear it that much.
Yeah. So looking forward, what's one thing that you are hopeful? We've talked about all the things that we don't like or
Mhm.
need maybe improvement, but for those that might be interested in healthcare listening or those that are still in healthcare and maybe need some hope, what's one thing that you're hopeful for?
Well, I'm a big science nerd. I think you guys all know that about me. And I just think that we're on this cusp. It's almost, if you're a Star Trek nerd like me, like this brave new world that's a part of us. Because if quantum mechanics actually do come, which I think they're going to come by the end of this decade, and if AI is leveraged the right way, and if we can leverage the EMR the right way, I just think that the next evolution of medicine is going to see people live longer, and not just live longer, because age doesn't mean anything if you're not healthy. And I think that the next future of medicine usually happens after a bad crisis. It's just the way that our history has been. Some of the best medicine we got was post-World War II, and that was such a horrible time, but that's just how it is. And this post-COVID world, I think that there's two things to look forward to. One is that we're on the cusp of, I think, of a revolution in medicine, where things are going to be much more tailored and things are going to be directed. And if you have individualized care, and you know me, especially with the ventilator, everything should be individualized for a person. I don't think that medicine fits in a box. I think that that is really exciting to look forward to, and that people are just going to live longer, but live healthier longer, which is so exciting. And the other piece of it is that I think I'm really excited for the next generation, because they're going to see things that we have never seen. I think it's going to kind of behave like the 1900s. And I hope I live long enough to see that transition, but hopefully not at the bedside for too much longer, where I can enjoy the rewards of this very long and treacherous career. So I'm excited for the future of the next wave of medicine, which is mainly going to be computer based.
I think despite having concerns about the younger generation, I'm also so hopeful because now the nurses and the residents and the practitioners, everyone that we're getting now, are ones that ran to healthcare during COVID. Like these are the ones that are starting to graduate, are the ones that started their journey in COVID, that saw the worst of what we've all experienced and said, yep, that's what I want to do. And Fred Rogers from Mr. Rogers' Neighborhood, I don't know if you know Haas, it's an American show, but he always said it's for kids, and he was famous for saying to tell kids, when you don't know who to go to, look for the ones running to the crisis. The ones running to the fire are the ones that are safe for you. And so all of these people running to healthcare in the middle of a crisis, those are going to be our safe people. Those are going to be the people that are so passionate and excited and want to help. So I am excited as we're starting to see them graduate from schools.
I can piggyback off of what the future holds and far of the big break in medicine. I mean, I I'm jaded. We all are, but I still really like being a bedside nurse. And maybe it's just the 4 years, but I find enjoyment in it. But when you look at trends of stuff that, in 2010, what we're doing now, and then early 2000s, what we're doing now, there's, in the 80s, and how stuff has changed so much. I hope I'm still doing this while those big changes happen, because there's a huge difference between what we were doing really not that long ago.
5 years ago.
So, yeah, there's
Mhm.
so much that could happen, and it's just exciting to see. It's the nerdy side of it all, but you're like, we're doing good now. I can't imagine it being better, but it will, just from studies and policies and procedures. That's the exciting part to see of it continuing to evolve for
Mm.
good patient care.
Mhm.
You want to close this out, Kaylee?
Oh, I mean, I think overall, like, I'm hopeful that just like healthcare in general is becoming more accessible to people. Like, you don't even have to leave your house sometimes to like go see the doctor. So I think that's really good for a lot of people that would maybe never go for whatever reason. But like we were talking about earlier about all the new grads and stuff coming out, at least for nursing, like I think it's hopeful that there's still so many people that are going into it and wanting to do the job. I think that hopefully like hospitals and healthcare systems can lean a little bit more into retention and retaining those good people at the bedside for a little bit longer so that we can bridge that gap and then have better training. But I mean, I think it is a good thing that we still have so many people going into healthcare and nursing and that still want to, help take care of people, especially like Abby said, after COVID and everything. So I think that that's really comforting and hopeful for the next generation.
Agreed.
Well, this has been a great episode, everyone. Thanks for joining us, and we hope to see you on the next round.
Yalla
Bye.
habibi.